morning, Dr. Patino here at the Cosmetic Surgery Center of Rosarito. We're going to do micro power assisted liposuction on this patient, and we're going to go ahead and start now. And you're gonna be the first ones to see what comes out of here, right? So our aspirate should be totally bloodless as usual, right? Look at that. Can you show it to them? See what's coming out here, right? Very, very nice surgery, right? Why is that? Well, there is many ways that go into this bloodless aspirate, right? The number one thing, we tell the patients not to take any aspirin, no ibuprofen, no herbs, no vitamins, like medications. The surgeon does not give any of those things, right? And the surgeon does not give any enoxaparin or heparin-like medications. Next, the patient tumescent the area, meaning we put anesthesia. This was developed by Dr. Jeffrey Klein. It's a type of anesthesia that was invented for liposuction. And we use it for all kinds of procedures. This has epinephrine to clamp down the blood vessels so that there is no bleeding. And all surgeons know about this technique. Not everybody uses it. Most people use it for liposuction, all right? She wants you to show this, okay? To show the fat, so that there is absolutely not even a speck of blood. This is the way we do it here at the Cosmetic Surgical Center of Rosarito, bloodless aspirate. This is incredible because that's how we do it, right? And another thing, look how my strokes are super slow. I'm not jamming that instrument back and forth. We use 4 millimeter cannulas, blind cannulas, very small cannulas that are atraumatic. So this is all incredible. Thank you. And I'm right-handed, but I'm ambidextrous, but I'm using my non-dominant hand, right? So this is also good for those surgeons. Even if you're not ambidextrous, you can use your non-dominant hand, but because the strokes are so slow, then that also protects the patient from internal injury, right? Because usually internal organ injury happens usually when the patient is being operated on by a surgeon that's already tired, maybe on a Friday night, after doing many cases, right? And loses situational awareness, right? So goes in an unintended area, sort of like when you're driving, you're tired, maybe you're sleeping or you have not slept, and you're like at night driving and everything, and that's how it happens. Thank you. Yeah, so we never had anybody die. We never had anybody with an internal organ injury, thanks to God, and we want to keep it that way, but I'm extremely meticulous to the point of being ridiculous, right? My strokes are way slower than most surgeons I've seen, and so that gives you less bleeding, but also protects the patient from internal injury. And also, this is beneficial for the surgeon because it is going to minimize the risk of repetitive injury to the surgeon. Like, for example, getting tendinitis at the shoulder level or at the elbow or at the wrist from doing this repetitive motion all day long, right? And especially for surgeons that do many cases, we limit our cases. We do 1 or 2 cases per day, and that's about it. So I'm not tired when I'm doing this procedure, you know, and it's beneficial for both the surgeon and the patient. Thank you. Alrighty, so in addition to that, we're doing a fat transfer to the buttocks on this patient. So guess what? This is what's going to go into her buttocks, right? It's bloodless, oil-less fat graft, right? What that means to the patient is that she is going to retain, instead of losing 30 or 50% of the fat graft, because a lot of it is blood and or oil, right? Mostly blood. How do you know that? Because when the surgeon puts the fat graft, it's red or pink. You know, ours is yellow, beautiful like this, right? And if there is blood there, the body is going to reject that blood and push it out into a callus. And that's the famous blood fracture, or an oil cyst, the famous oil cyst. which we never had, and want to keep it that way. Thank you. Alrighty, so the patient is on her side. We call it the lateral decubitus, right, Dan? Yep. And she's doing great. Thank you. Alrighty, so the patient is on the side. The buttocks are over here. I'm gonna cover the buttocks over there. But basically, this is what we call the pinch test. Can you see that, Brett? The pinch test. See, that means we're pinching. Yep. And can you see that? Yep. That there is absolutely no excess fat here. We're down to like 0.5 centimeters everywhere you pinch on this lady, right? Everywhere you go. There you go. It's the same, right? So she doesn't have much fat left. You know, we cannot take it all, but basically we did a very good job. Same here, see? Everywhere we go. And now we're gonna turn her on the other side and do the other side. Thank you. So see the difference between one side and the other? We're gonna give her this nice waist. She's on her side, and again, I'm using my non-dominant hand, so my strokes are very slow. That's how we do it. Thank you. Emily, so what do you think about that aspirin?
Wow, so golden yellow.
Golden yellow, man. It is right. It is basically bloodless and oil-less.
Wow.
This means you're gonna retain more of the fat graft. Instead of losing 30 or 50%, you're gonna keep it all, probably. Thank you. All right, so we are done. So she's on the other side. We still need to do the fat transfer, but look at this. Can you see the pinch test here also?
Oh,
look at that beautiful waist, Emily, huh?
Wow.
Can you see when I pull it up, even up there?
Yes.
Even to the back, all the back side here.
Yes,
the buttocks are over here. She's on her side. This is her beautiful waist, you guys. Incredible. Thank you so very much. Look at that. Thank you. Wow, so we did high definition on the back also. So these are the paravertebral muscles here, you see? On this side, looks very nice. And now we're gonna do the buttocks. Fat transfer to the buttocks in a minute. Thank you. Alrighty, so look at that fat graft we're putting in there. Completely oilless and completely bloodless. That means she's going to retain all this fat. Why? Because this is basically pure fat, you guys. This is the way it came out, and this is the way it's going in. And this is just incredible. So if you want to have more fat graft retention, this is the way to go. And to do it, you have to basically collect the fat in an atraumatic manner so that the fat graft is devoid of any blood or oil, because the oil also results from trauma to the fat cells, and then they leak the oil, right? Then the oil does not belong outside the fat cells. The blood does not belong outside of the blood vessels, right? So when you do this in a bloodless, oilless manner, so we put.
All right, so we're doing ultrasound guided gluteal fat transfer. This is the patient's skin. And down here we have Dr. Patino's cannula. It's above the deep gluteal fascia and below the superficial gluteal fascia. So the doctor's going to wiggle the cannula for us. So we can see that that's the cannula, it's wiggling. You could see how if you didn't have ultrasound, it would be very easy to go a little bit deeper and be underneath the deep gluteal fascia, which you don't want to do because that's where the striated muscle is, and that's what could be very, very bad for the patient.
Righty, and so I'm going to give it a bolus. Look at that tip of that cannula right there. See? Right there. And there, you're going to see a great cloud as the fat graft enters the deep subcutaneous space. 1, 2, 3, go.
So you see how that gray cloud is entering and the deep gluteal fascia is getting pushed down? That's from the pressure of the fat that is entering the subcutaneous space, the deep subcutaneous space right here between the deep gluteal fascia and the superficial gluteal fascia.
Thank you.
Go. All right, so we're on the other side, and we can see the deep gluteal fascia right here at pretty close to 4 centimeters, and then this is the superficial gluteal fascia. Doctor's in between the two in the deep subcutaneous space. This is his cannula. He's going to wiggle it.
Yeah, and we already put some fat in there, so you can see that gray is the fat that we already put in there. So this is very good, and we move from one bottle to the other every 100 ml of fat graft. So here we go, 1, 2, 3. You see it?
All right, so we're seeing fat enter the space right here.
And we're gonna do it again. So here we go. 1, 2, 3, go.
All right, see this bolus of fat? It's entering the space, and you can actually see the deep gluteal fascia get pushed down as the fat enters the deep subcutaneous space.
Thank you. Results, because see, I can see below the cannula, all that is full of fat graft already. But above, just above there, just below the superficial gluteal fascia, we can sneak in some more fat graft. So I'm going to do that. So you see? But I would not know that if we were doing it blindly, the way that this procedure is commonly done. But through the World Association of Gluteal Surgeons, we can teach doctors how to do this procedure. See how that's filling in nicely, right? In a very controlled, safe manner, right? So that, yeah, and we have about 15 centers in the United States and abroad through the World Association of Gluteal Surgeons, of which I am the CEO. And Dr. Miami, famous Dr. Miami, is the founder. So I see I'm going to put a little bit in this empty space right there. So it also helps me with the aesthetics, right? So how else would I know that you need a little fat there, right? It's incredible. Thank you.